I think the next speaker is not here. In fact, we are being taken to Phoenix, Arizona by a Skype presentation, and Dr. Rajesh will introduce the speaker.
Dr. Nakra, can you see us?
Yes, I can.
Okay. I think the next talk is on surgical offloading in the diabetic foot. Again, the same question that Dr. Madhu had asked now, prophylactic surgeries for the diabetic foot. Dr. Nakra, I think you can start. Thank you.
Oh,
Your
thank you.
PPT is not on.
Let's see. How about now?
It's on?
Can you guys see the?
Yeah, it is on now.
Perfect. Thank you.
Thank you.
Well, folks, thank you for attending this talk. It's about 10 o'clock at night here, and it's July 4th here, so John would appreciate this. The whole sky is lit up with fireworks. So I was running back, forth, in and out. I just wanted to make sure I didn't miss my turn for lecture. The whole sky is just absolutely lit up. So it's just a beautiful time to be here. Since this is my last talk, I wanted to thank the organizers for inviting me. I'm sorry I couldn't make it there, but hopefully we've been able to get the point across that these limbs are salvageable. This is a team approach. And as long as our basics are strong, we build on those basics and we can do some very good work. So for the next 30 to 40 minutes, I think I was told I had 40 minutes. I'm going to share with you some surgical examples of how these limbs can be salvaged. And I'll share pre-ops and post-ops with you so you can appreciate the amount of work that goes into saving these limbs. And because there's so much work that goes into these limbs physically and mentally, before you start on this journey, you have to ask yourself, what is the risk versus benefit? Because essentially what we're trying to do is prevent an amputation, be it a toe amputation, be it a Symes amputation at the level of the ankle joint, or be it a below knee amputation. So you have to have a candid conversation, not just with the patient, but with yourself, that is this limb salvageable? If you come to the conclusion that, yes, I think I can save this limb, you have to then decide, is the patient a candidate? Is the reconstruction worth it? So you have to make sure these patients are medically managed, and we'll briefly touch base on that. But you have to appreciate from a surgical standpoint the anatomical and the physiologic concerns, because these feet, these ankle are dislocated, as you can see on your see an example on your right hand side. So you have to have a very well thought out plan and determine what is it that we need to do, because doing more is certainly not better in this case. You don't want these patients under general anesthetic for prolonged periods of time because you have concerns of wound dehiscence, concerns of acute Charcot, a surgery starting acute Charcot. So there's a lot of thought that needs to be put into these patients to determine if they're candidate for surgical management. Why do we do all of this? Why are all of you giving up your weekends, sitting in this conference hall, trying to get better at this? Why? Because we want to minimize the risk of amputation. By surgery, if these patients are candidates for surgery, and when I say if they're candidates for surgery, is their sugar well controlled? From a cardiac standpoint, can their heart handle the prolonged surgery and the prolonged anesthesia? Are they medically viable candidates for surgery? If they are, then you need to outline the goals and expectations of surgery. And the number one is you want to prevent the ulcer from reforming, because from the talk yesterday, and I'm sure it's been reiterated by multiple other speakers, it's that ulceration is the precursor to the amputation. So if we can prevent that ulcer from forming or cause prompt a rapid healing of that ulceration, we are reducing the likelihood or reducing the risk of amputation. In addition, via surgery, we're trying to give the patient a plantigrade bracable foot. I routinely say this to my patients that for the reconstructions that we undertake in these diabetic patients, I am not trying to give them a foot or an ankle that belongs in the Cosmopolitan magazine or the Femina magazine in India. I'm trying to give them a foot that is plantigrade. So it's a stable foot, it's braceable. These patients will require lifetime bracing if we proceed with surgical reconstruction. And certainly, like I said, the goal, of course, is to salvage these legs because of the much higher risk of contralateral amputation and the higher risk of mortality. So before we decide to undertake this lengthy journey, we have to understand the biomechanics. We have to understand the anatomy. We have to appreciate the anatomy. You have to have a well thought out plan to determine if this patient is a candidate for surgical reconstruction. And if it is, how are you going to proceed so you can accomplish the goal of providing stability, accomplish the goal of giving the patient a braceable plantar foot, which reduces the likelihood of an ulceration and subsequent amputation. The common issue that we deal with in all of these patients is neuropathy, and I briefly mentioned this yesterday. We all know they're dealing with sensory, motor, and autonomic neuropathy. And that's another reason why these patients have to be braceable, that these deformities will be progressive. And that's the reason we want to brace these patients even after we do these prolonged and complicated surgical interventions because of the underlying denominator of neuropathy, which will persist. So when you're seeing this patient, no amount of biologics or debridement is going to make that ulceration on that plantar, on that lateral malleolus, and another ulceration that's developing on that plantar or lateral aspect of the fifth metatarsal brace go away until this foot, this ankle is realigned. This ankle is not braceable because the patient continues to get an ulceration. And it's cases like these, if they're medically well controlled, that's when you undertake intervention on these patients. And you can see how this patient is significantly immunocompromised. He is liver and kidney transplant. And if this ulcer persists, he will end up with an amputation. And given that he was medically well controlled, we decided to proceed with a TTC fusion, tibio-talocalcaneal fusion via an intramedullary rod. And hopefully you can appreciate the pre and the post-op difference, how the lower extremity looks preoperatively and postoperatively. We've been able to realign the lower extremity and take away that high pressure point that exists on that lateral malleolus, which has that chronic ulceration. If that ulceration doesn't heal, this patient will end up with an amputation, and the patient's also getting another ulceration on that fifth metatarsal base. So by realigning this lower extremity, we were able to prevent this patient from an amputation. So the key before you start out on this journey of undertaking these reconstructions, you have to have a team who takes part in the medical management. We want to make sure these patients are candidates for the surgery, and that's the reason it's very important to have appropriate clearances on these patients, so you're setting yourself and the patient up for success. I think I briefly mentioned this yesterday. There are predictors for wound healing. No amount of screws or plates or biologics is going to cause healing if there's certain parameters that are not met, such as albumin. This is an indication of the patient's nutritional status. Total lymphocyte count. It's an indication of the patient's immunological status. And we certainly spoke about the vascular status yesterday. So if there isn't enough blood supply going down to these limbs, no amount of surgery, no amount of technology is going to heal these wounds. We also briefly spoke about that in a lot of these cases, we're dealing with open wounds. So we have to make sure that the underlying bone is not infected, or if it's infected, how do we manage these wounds appropriately and obtain realignment at the same time? So please proceed cautiously and understand the tests that are available that we can order, and also the limitations of each one of these tests as we spoke about. Osteomyelitis and Charcot, they can be very deceptive. Till today, having been in practice even for close to 15 years now, till today there are times when I have to take a step back and go, am I dealing with osteomyelitis? Am I dealing with Charcot? Or am I dealing with a combination? Because that will alter your surgical plan. So do your due diligence before you start on this journey. So let's briefly go through some of these cases so you can appreciate some of the surgical procedures that are involved in salvage of this lower extremity or foot and the ankle. Somebody for the previous lecture had asked the question of equinus. So let's first start by defining equinus. Equinus is limitation of dorsiflexion. And as the slide appropriately says, it is considered the Achilles heel of ulcers and diabetic Charcot. You absolutely have to check for equinus, because majority, if not all of these patients, have an underlying equinus component that's leading to breakdown, which is leading to Charcot or is leading to non-healing of the ulceration. Multiple studies, I'm just touching the tip of the iceberg, but there are multiple studies that have been described that talk about the correlation between equinus and diabetes. It's that glycosylation that occurs of the tender Achilles that leads to tightening of the heel cord, leading to the biomechanical aberration that occurs. And this is how it occurs. When you have a tight heel cord, you're pulling that posterior heel superiorly, which leads to breakdown in that medial column, leading to a Rocker bottom foot type. And I'll share several examples with you. And you can see once you have that breakdown in that midfoot, you end up with that ulceration at that pivot point. And this is that midfoot Charcot, that midfoot collapse that you hear all of us talk about, that you hear being described in the literature. So we have to address that equinus component. And so let's take a look at some clinicals. So this is that classic rocker bottom foot. Hopefully you can appreciate that the heel's not even touching the floor, because that's how tight that Achilles tendon is. And because of that tightness of that Achilles tendon, it's leading to midfoot collapse. You can see the infection that's going on over here because the patient has a plantar ulceration at that pivot point. Hopefully you can appreciate that rocker bottom foot type on the lateral column, which is leading to gross instability for this patient. Once again, the Achilles tendon goes up and you get midfoot collapse, leading to that classic Charcot midfoot that we talk about. And the patient has that ulceration where you see that marker on that plantar aspect of the foot, that radiographic metal marker. That's where the ulceration is, exactly where the pivot point for the equinus is, because of the tight heel cord. So we have to appreciate and acknowledge the dramatic effect Achilles tendon has in any reconstruction that we undertake for Charcot feet, for diabetic ulcers, because if we don't, these feet our surgical course will collapse. This is another example of Charcot, another example of a severe equinus. You can see the negative calcaneal inclination angle on your top left, the X-ray. You can see how the calcaneus is protruding downward, leading to that midfoot collapse, leading to that rocker bottom foot type, leading to that ulceration on that plantar midfoot. And that's when you have to appreciate that we can certainly realign the whole foot and the ankle. We can do plastic surgery and close up these ulcerations, but we have to appreciate and acknowledge and address the equinus component associated with these diabetic feet and Charcot. Once again, multiple studies that have been published. I'm just mentioning a few of them that talk about the role of equinus in diabetic feet. This is an example of a non-healing plantar MPJ, metatarsophalangeal joint ulceration, that wasn't healing. And I took this patient for a tender Achilles limping. And we had spoken about this yesterday. In diabetic feet, it's rare, if ever, I utilize a gastric venous recession, because tender Achilles limping is a much stronger procedure, and you're addressing the true cause. You're addressing that glycosylation of the collagen fibers of the Achilles tendon, and hence you want to proceed with a tender Achilles limping versus a gastric venous recession, which is what we did in this case. We did a tender Achilles limping, and you can see the post-operative result which occurred, which led to healing of the ulceration on the plantar aspect of the MPJ. Several ways of accomplishing this. The way I do this is, if I'm doing an isolated tender Achilles limping, as was in that example I showed you previously, then yes, I'm going to do it open. I'll have the patient supine prone, depending on anesthesia preference. If I'm doing a complete reconstruction, then I very much likely will proceed with the patient in the supine position, lifting the leg up and either doing an open or probably percutaneous tender Achilles limping. My personal preference is a 3-cut approach, 2 medial, 1 lateral. This is what you're trying to accomplish. You can see the 2 medial and 1 lateral. And essentially you can see the lengthening that you're getting of the Achilles tendon to address that the tightness, which is leading to the biomechanical aberration, leading to that midfoot collapse. So this is what an open tender Achilles lengthening when a percutaneous tender Achilles lengthening is opened up, this is what it looks like. You can see that the two medial cuts and a lateral cut, and you can appreciate the lengthening that we get with this. So this is a clinical example. A 45-year-old male with ulceration. Patient has had 4 prior surgeries, but continues to get this non-healing ulceration on that plantar lateral column. And it's those ulcerations on the plantar lateral aspect that are the hardest to heal. And that's when you have to go, what is it that we're missing? The patient's had appropriate forms of surgical intervention, but it's not healing. And you can see the midfoot collapse that's occurring in this, especially you can appreciate it on the lateral, the midfoot collapse, which is leading to that overloading on that plantar lateral aspect. And essentially, we took this patient for tender Achilles lengthening. On your left is the pre-op, on your right is the post-op. You can see the increase in the sagittal plane dorsiflexion of the foot and the ankle, leading to healing of the ulceration. In my hands, a tender Achilles lengthening is kept non-weight bearing for about 4 weeks, 3 to 4 weeks at least, for fear of spontaneous rupture. And you can appreciate how this ulceration has healed up. So hopefully you can appreciate the role equinus plays in these ulcerations, because one of the delegates had asked that question after the previous talk. So you can appreciate the role equinus plays, and so understanding the fundamentals, your physical exam will help you appreciate what you need to do with these patients. And you can see how this ulcer stayed healed by addressing just the equinus component associated with this. Just like with anything that we do, there are pros and cons with everything that we do. With tender Achilles lengthening, these are the expected consequences: flexion substitution, which can lead to formation of hematose. So you have to worry about high pressure points that are created dorsally and plantarly. I made this remark yesterday that you got to be careful when you're doing tender Achilles lengthening, when you're doing them percutaneous. My fear is always of an Achilles tenotomy and leading to an over lengthening, because that can lead to calcaneal bursitis or plantar ulcerations, and I'll show that to you. So this is an example of a Charcot midfoot collapse. You can see the pathology that's occurring at the midfoot joint. You can see the obvious dislocation that's occurred. So this patient, of course, we decided to take this patient to surgery. And I made this remark yesterday that in my hands, medial column fusion is of the utmost importance. If I can stabilize the medial column, I have a very high success rate. In my hands, as I'm getting older and just have had enough experience and having enough failures, frankly, I've come to realize that in my own hands, and that's certainly confirmed via published literature, that addressing that medial column is of most importance, which is what I'll share with you. And hopefully you can appreciate the incision, that medial incision where I performed a medial column stabilization, but you can hopefully also see that ulceration that's present on that plantar heel, that hypokeratosis, because my concern is that I very likely over-lengthened the Achilles tendon when I did a percutaneous TL, that I probably was a little aggressive. Fortunately, this was well controlled because these patients are braced, in my hands, are braced lifetime, so that suddenly did not become an issue. I'm going to show you an example of what happens if you don't address the equinus component. This is a 3-hour surgery. You provide stabilization, you do realignment orthodesis to provide stability, to realign the deformed foot. But if you don't address the equinus component, within a matter of 2 years, I've got complete collapse through the midfoot because the patient, the equinus component was not addressed. So you have to check for it. You have to have a high index of suspicion for equinus, because all your hard work will go down the drain if you don't look for this equinus component. So please look for it, appreciate it, respect it, because the consequences can be disastrous. So this patient was referred to me because of this particular case. I did not do the original surgery because of this complete collapse that occurred to through the midfoot. The equinus wasn't addressed. I took the patient back to surgery and did a complete medial column fusion on this patient. And patient went on, fortunately, to do very well. But the point once again being, look for that equinus component. because it can certainly come and cause a lot of headaches. I've been there multiple times. This is another example. This patient was actually advised to have a below knee amputation. I was the last stop for this patient. The patient was told that, hey, if I can do something for the patient, so I frankly told the patient, hey, we'll give it our best shot. You can appreciate the severe equinus component. Look how flat that calcaneal inclination angle is. Look at that medial column collapse on that lateral view. You can see the dislocation that's occurring. And you can see that non-healing ulceration on that plantar midfoot. It's been chronic. It's been present for multiple months. This foot is not braceable. So we decided to take this patient to surgery. We did an ulcer excision. We did an exhaustectomy. Hopefully you can appreciate on your extreme right the osteotome that's been that we are utilizing to resect essentially that prominence. I unfortunately can't point to anything, but hopefully, can you folks see my arrow when I circle? Perfect. So when I'm doing the exhaustectomy, I'm essentially knocking off this plantar aspect of the cuboid. And you can see this is what we are doing. We've got this non-healing ulceration. We excise the ulcer, do an aggressive exhaustectomy, and then we do a closure. And this is where, once again, different kinds of plastic surgical flaps, you have to have a good appreciation of the angles that you have to use to enable closure. And that's what we were able to do. Put the patient in an X-fix because I wanted to keep a close eye on that plantar wound. And you can see the pre and the post. This is 7 months post-op. So this patient was told to have a below knee amputation, and you can see the patient we were able to salvage his leg. So fortunately, a very good result, but once again, appreciating combination of your physical exam, your surgical technique, appreciation of the deformity that leads to the result that we want. Another topic that I would like to talk about in this surgical talk is calcanectomies for heel ulcerations. We see a fair amount of heel ulcerations in diabetics. An example is right here in front of you, an ulceration, non-healing ulceration on the lateral aspect of the calcaneus. And in these cases, in my diabetics, I'm quite aggressive at doing the calcanectomy. Once again, excising the ulceration and doing the calcanectomy. So I'm sure going to share an example with you, but once again, you've got to take these patients through the due diligence to make sure what is it that I'm dealing with. And of course, an MRI and appropriate testing was ordered on these patients, and the patient had underlying osteomyelitis. So we decided to take the patient to surgery. We did a calcanectomy, and you can hopefully appreciate the beads, the antibiotic beads that were placed in that wound. So I put these antibiotic beads in. So I'm putting a loc because there certainly was a component of peripheral arterial disease. And I wanted to make sure that we have complete healing of this wound. They decided to do that, and the patient went on to do very well. This is another example that chronic heel ulceration. The key over here is we've got to appreciate our angiosomes. We know the angiosome, that's for all of you folks who do calcaneal fracture, reduction of calcaneal fractures, that this area has a very high area of dehiscence. So you have to be very careful with your dissection technique over here. So you want to create a full thickness flap. Once again, a partial calcanectomy, but once again, knowing your anatomy that I've got to reattach that Achilles tendon. I don't want the Achilles tendon flapping in the air because I'm going to end up with hyperdorsiflexion leading to plantar heel ulcerations. So hopefully you can appreciate where the Achilles tendon has been tagged with the suture, and I essentially drill holes in the calcaneus because I don't want to put any form of metal in an area that's infected. I just drill holes in the calcaneus and essentially suture it back into the calcaneus. And this is what it looks like. The Achilles tendon has been reattached. And this is what it looks like post-operatively. We were able to excise the ulceration, have primary closure, reattach the Achilles tendon. And because we were dealing with osteomyelitis, the patient was placed on long-term antibiotics. And you can hopefully see the pre and the post. The incision went on to heal completely, and the patient had a very good outcome. Another example, same thing, the ulceration probes to the Achilles tendon. We open the Achilles tendon. The distal 1/3 of the Achilles tendon is just not viable. So once again, you can see the aggressive calcanectomy that's done because this is limb salvage. The Achilles tendons involved, the calcaneus is involved. Patient has been told to have a below knee amputation. So at this stage, you want to be aggressive. You don't want to be taking little pieces. You want to save these legs. You've got to be aggressive. So you can see the fair amount of calcaneus. I'm really going as much as to the posterior subtalar joint, resecting that calcaneus, debriding the Achilles tendon on the left-hand side. Hopefully you can appreciate the residual, the distal tip of the residual Achilles tendon. And now I have a huge gap to fill. I've got to reattach this Achilles tendon to the residual calcaneus, and this is when we do a flap down. So you essentially extend the incision and do a sagittal plane, a coronal plane reflection of the residual Achilles tendon and attach it into the residual calcaneus. And you can see the final result. Patient went on to do very well. We were able to save the leg. So once again, appreciating the anatomy, appreciating what techniques we can use, and determining if we can save these legs. How do these patients walk? I showed you quite aggressive examples of calcanectomies, and there's multiple studies that have been published on this. If you reattach the Achilles tendon to that residual calcaneus, the weakness of plantar flexion is usually very minimal, and these patients are braced for a lifetime. So from an ambulatory perspective, these patients continue to be ambulatory, and we're able to save these legs. The next topic that I would like to talk about as we continue talking about surgical reconstruction of the diabetic foot is that classic midfoot Charcot. I've shown you several examples so far on what these feet look like. The key over here is, once again, appreciating that equinus, because that is certainly playing a very deforming role in that midfoot collapse that we see leading to that ulceration. The decision that you have to make, and this question came up yesterday, the decision that you have to make is, when do you do an exostectomy and when do you do a lengthy arthrodesis? So let's kind of briefly talk about that. So an arthrodesis is labeled on your left, and an exostectomy or an ostectomy is on your right-hand side. You want to use an arthrodesis type of a procedure when you're fusing multiple joints, when you are dealing with an unstable midfoot that is not braceable. So that's the key over here. If these patients have failed previous exostectomies, you certainly want to proceed with an arthrodesis type of procedure, and I'll show you an example of that. We all know the Eichenholz classification. Stage 3 refers to that final stage, the coalescence stage. And generally in my hands, that's where I go to fusion type. If I have a failed exostectomy, or in my hands, the extremity is not braceable. Just to refresh your memory, I showed you an example of an ankle Charcot earlier on at the start of the lecture, where the ankle was in complete varus. It was completely dislocated. So that's a non-braceable deformity. So certainly just excising the fibula would not be enough. We proceeded with the tibio-talocalcaneal fusion via IM rod, and that's to provide stability. So it's for these unstable feet, unstable ankles that we want to proceed with an arthrodesis. The non-braceable lower extremities that we proceed with arthrodesis. A prior failed exostectomy or a recurrent ulceration, that's when we proceed with an arthrodesis kind of a procedure. So let's take a look at some examples. So you can hopefully see the obvious collapse with the plantar ulcerations in the midfoot. And once again, it's that same constant point. If you notice, it's that same ulceration that continues to show up in these patients. And so you have to appreciate the role of that tight Achilles tendon in these patients. So we decided, in my hands, I felt this was a stable foot. I didn't, in my clinical exam, I did not appreciate any gross instability. Patient had not had any prior surgical intervention. So we decided to proceed with an exostectomy only with a tender Achilles lengthening versus proceeding with a fusion. So this is what it looks like on the plantar aspect. You excise the ulceration and you excise the very prominent exostosis, and I did not have to do any flaps or move any skin rearrangement. Primary closure, and the ulcer went on to heal up, because if I felt that the deformity was stable enough that a resection arthroplasty in combination with the tender Achilles lengthening gave us the result that we want. Another example, you can see the on your left-hand side, the non-healing ulceration. We proceeded with an exhaustectomy, and this case was actually referred to me because this patient had multiple exhaustectomies previously. So you can see the first exhaustectomy, you can see the second exhaustectomy, and you can see the third exhaustectomy. It is just not healing. And that's when you go, you've done 3 exhaustectomies. Why is this ulceration not healing? Because you've got an unstable, non-braceable foot with a recurrent ulceration that continues to get infected. So this patient was referred to me, and in my hands, I was not going to do a 4th exhaustectomy. I decided to take this patient to surgery and do a complete realignment arthrodesis on this procedure, on this patient. This is what the X-ray looks like. There's really, frankly, nothing else left for me to do an exostosis on, and that was another reason we said we're going to do a realignment fusion, and this is what it looks like 1 year post-op. Once again, that medial column has to be stabilized in these patients, and this is what the post-op looks like. You were able to salvage the leg. This was limb salvage surgery. Patient had had 3 prior surgeries with a recurrent, and the ulcer continued to return, continued to get infected. The foot was grossly unstable, and that's when you proceed with a realignment arthrodesis. And hopefully you can see the incision on the medial column. The incision is right here. The complete medial column fusion was performed right here, along with the tender Achilles lengthening to enable the closure of this ulceration. At 1 year post-op, the patient continued to stay closed. And this is 5 years post-op. You can see the patient's closed, and this patient has been braced for their life. And once again, you can see the incision. You can still appreciate the incision over here. The key is, once again, and I've said this multiple times and I'll continue to say it, it's the medial column fusion. You've got to provide stability to the medial column if you decide to proceed with this realignment arthrodesis kind of procedures. This is another example where we decided to do a realignment arthrodesis on this patient, and you can see the pre and the post, 1 year post-op. You have to recreate that medial arch. You have to address that Achilles. You can hopefully appreciate the incision over here that was made for the Achilles and the incision that was made for the medial column fusion. And of course, you can appreciate the obvious change in the architecture, improvement in the architecture of the foot that led to healing of the non-healing ulceration that was present in this patient, right plantar aspect over here, and we were able to save this leg. So as we kind of moving more distally, I just want to show you some cases of forefoot surgery. There are multiple ways of doing this, depending on where the ulceration is and what the biomechanics are. On your right-hand side, you're appreciating an ulceration on that plantar interphalangeal joint. So how do you treat these ulcerations? In this case, we decided to do essentially excise that plantar IPJ sesamoid and do an interphalangeal joint fusion, and you can appreciate the ulceration that has healed, because the key is if this ulceration doesn't heal, it gets infected. You're going to start out by taking the toe off, then you're going to end up with a partial first ray amputation. Unfortunately, the domino effect will persist. So we've got to close up these ulcerations as rapidly as we can to minimize the risk of infection, minimize the risk of recurrence, and minimize the risk of amputation that occurs with these ulcerations. And subsequently, we took the screw out because the patient started to develop an ulceration at hyperkeratosis at the distal tip. So before it got infected, I just went ahead and took the screw out, and the patient continued to do very well with no recurrence. And these patients are put in custom molded diabetic shoes with these inserts in them, Plastisode inserts in them, so that these patients are managed, are controlled. There is biomechanical control of these deformities for a lifetime. Another example, this is a plantar forefoot non-healing ulceration. This is what the X-ray looks like. You can see the immense amount of collapse that's occurred. You're dealing with obvious osteomyelitis. Hopefully you can appreciate the complete erosion that you're getting, especially at the third MPJ. You can appreciate the obvious subluxation. To a certain extent, the X-ray looks like a rheumatoid, that fibular deviation. But since the patients are diabetic, these prominent metatarsal heads and this complete collapse, and you can see the cortical erosions, which is leading to this ulceration. This ulceration does probe to bone, But is it just probing to bone that makes me go, this is osteomyelitis? No, it's the combination of the X-ray, which shows obvious cortical erosion, the SED rate, which is elevated at 75 and above. The ulcer hasn't healed for multiple months. It's got a malodor to it that we decided to proceed, and appropriate diagnostic testing was ordered, and that we decided to proceed with a pan-metatarsal head resection on this patient to heal up this ulceration. And this is what it looks like post-op. This is what the X-ray looks like post-op. And this is, you can see how it led to healing of the ulceration. And you can see my incision was made plantarly. This is the incision over here. And that way I was able to excise the ulceration, resect the metatarsal heads, and patient went on to do very well. Some more examples. We see this in our office, that ulceration at the distal tip of the toe. And in these cases, it continues to get infected. And then once again, you start going down that slippery slope of having to do that, doing the distal signs, and you've just started the ball rolling of the amputation. So moment that ulceration occurs, it's a relatively flexible deformity. I'm going to just do a flexor tenotomy. And so many times we do this right in the office with the 15 blade. These patients are neuropathic. Stab incision on the plantar aspect in the crease of that interphalangeal joint, and you resect the do a flexor tenotomy. And you can see the 2-year follow-up on this patient. You can heal up those ulcerations with no loss of and no amputation. There are multiple causes of digital ulcerations, and once again, we need to appreciate what is the cause of these ulcerations. That will help you decide whether you should do an exhaustectomy or whether you should do an interphalangeal joint arthrodesis, as I showed you. I just want to show you an example of an exhaustectomy at the forefoot level. You can see this non-healing ulceration at that plantar interphalangeal joint. And you can see the at that interphalangeal joint, the exhaustosis, the hypertrophic bone that's present over there. The joint looks pretty darn good, but we decided we're just going to do essentially an arthroplasty at the level of the interphalangeal joint. And you can see what this looks like. And this is another example. This is an example of an ulceration that was occurring on the plantar aspect, versus this is a little bit more medial. This is more plantar, and that's because you're dealing with this hypertrophic interphalangeal sesamoid, which is what's marked out over here. You excise that sesamoid without doing an arthroplasty in these patients, the wounds heal up. So in conclusion, the key here is, why do we go through all of this? We put our patients through these lengthy surgeries. We put ourselves through this physical and mental trauma. I've shown you some good examples. I have my share of nightmares. Not every reconstruction that I've taken has been a success. And that's the reason it behooves us to have a very candid conversation with the patient and with yourself to determine what is it that we are trying to accomplish over here. To start out with, is the patient or surgical candidate from a medical standpoint, from a biomechanical standpoint, from a psychological standpoint? These surgeries take a very long time to heal. They are fraught with complications. The failure rate is higher than the success rate. So your due diligence process has to be very diligent. The final goal still is, we want to prevent that ulceration from forming, because it's that ulceration that will lead to an infection and unfortunately will lead to an amputation. So these surgeries, to a certain extent prophylactic surgeries, are limb salvage surgeries, because we want to give these patients a plantar-grade braceable foot, which reduces the risk of amputation. Thank you.
Dr. Nagraj?
Yes.
Can you come online? We want to see you. Your video is not.
Sure. Can you see me?
Not yet. Yes.
Okay, perfect.
Okay, thank you very much for the excellent presentation. We would like to take some questions.
Sure.
Madam, I am an orthopedic surgeon from Chennai. After your calcanectomy,
Come.
yes. Yeah, after your calcanectomy, how do you reattach the tendo achelis, and how do you achieve the length of it? And because for every gate stands and your faces, you require tendo achelis, isn't it? Once you take off your tendo achelis, how do you achieve the length, and where do you exactly reattach it? Do you go for any tube first procedure or something? Do you use your plantaris tendon, or you straight away reattach it?
No, once you resect the residual calcaneus, I'm doing a partial calcanectomy, so there's still some calcaneus left. So essentially what I do is I take K-wires and I drill 2 holes from superior to inferior. So right where the superior aspect of the calcaneus is, I take a 0.062 K-wire and drill 2 holes and essentially attach the Achilles tendon to that residual superior aspect of that calcaneus. In the event that the Achilles tendon is not long enough because you've debrided the Achilles tendon, and I showed an example of that, and if you want me to, I can gladly bring that up again. If you don't have enough length, then you have to go proximally and do a flap down procedure. Certainly some of the textbooks, like the textbook that we have through the Podiatry Institute, that's very well described in that textbook. You essentially do a flap down where you take the Achilles tendon and you cut it into half in the coronal plane, and you flap it down and get your length back, and then reattach that into the calcaneus. I try very hard not to use any metal because I don't want to leave any metal in there because of the chronic ulcerations, fear of infection, etc.
Do you loop the tendon around the bone, or in the inferior aspect?
No.
Or no?
No, I don't loop it down the. It's essentially you do to a certain extent. You do like kind of like a Krakow technique. Are you familiar with the Krakow technique?
Yeah, I'm familiar.
Perfect. Yes, you're an orthopedic surgeon. You would be. Essentially, then I tag it into the residual superior aspect of the calcaneus.
Calcaneum being a cancellous bone, does the attachment hold well?
It actually, yes, it does. You would think it would not, but it actually does, because remember, you still have that cortical rim to the calcaneus. It's that inside that's the calcaneus. You have a very good, strong cortical strut. That's what you're using.
Thank you.
Oh, you're very welcome.
I think there are no other questions. Thank you very much, Dr. Nakra, for spending 2 very, very productive days and excellent presentation on various difficult topics. And from the organizers of High Care and from all the audience here, we would like to thank you profusely and spending such a late night and taking your time off. Thank you very much.
Oh, no worries. Thank you very much.
Okay, with this